Okay, so welcome again to everyone who's joining us today, especially if you weren't here last night. A special welcome to your first day with us here at the forum. We're very excited to have you here. My name is Kate. I'm a nurse and I work with the Children's Tumor Foundation, and I help to put this forum together every year. It's one of my favorite things that I get to do. And I'm really hoping that next year we get to do this and be together in person. We're always sad to not be able to do that, and I'm looking forward to having the opportunity, hopefully in the near future. I want to start, we're just going to put up a few slides and go over just a little bit of kind of Zoom housekeeping and some helpful tips for you as we go through everything today. So again, we're excited that you're here. So to start, this is for our speakers who are joining us today. If you're not the one presenting, we just ask that you have your video off and your mic muted. This webinar will be recorded today. Resources are always available beyond what you hear today at our website, and I definitely encourage you to visit ctf.org and check out what we have available there. Closed captioning is available. You can select that at the bottom of your screen. There should be a CC button to turn that option on. Now, the very important tip is that everyone, including English speakers, you need to choose a language because we are providing Spanish translation today. So in order to do that, you will see at the bottom of your screen a small globe button. If you click on that, it will say that you're in default mode. You need to choose English or Spanish. Please do not stay in default mode. That might interrupt your enjoyment of today's event. Once you've done that, oh, and a quick note, if you are joining from a smart app, like a smartphone on your app, you might see it as a more option or the three little dots. I know that iPhones use those. If you select that, you'll see language interpretation, and that will give you the chance to choose your language there as well. So to our participants today, we want to encourage you to please put any questions for any of our speakers into the chat box. It's really meant to be as interactive as possible given the limitations of Zoom. So no question is silly. Last night our group was real quiet, which is fine, but I just want to encourage you that our speakers are here to talk to you and to help you and to understand what's going on in the world of NF. So don't be shy, put those questions in the chat. If you're thinking it, someone else is bound to be also wondering about the same exact thing. Okay, so I'm very excited we're here, and I think we are ready to get started. I'm going to hand things off now to our wonderful forum co-chairs, Dr. Stedke, Dr. Listernick, and Danielle Bonadies. I'm going to hand things over and let you meet these great folks.
Great. And thank you, Kate, for this introduction. Hello, everybody. My name is Verena Stedke, and I am very honored to be part of this year's NF Forum. It's certainly always a big highlight of the year. I am an associate professor at Johns Hopkins. I am a clinician scientist, and I spend a large portion of my time in the laboratory that is working on gene therapy approaches for NF. When I'm not in the laboratory, I serve as the director of pediatric NF here at Hopkins and see patients, mostly children and young adults, in our NF clinic. And as I said before, the NF field is a very exciting field to be in at the moment, because I truly believe that with the support of the CTF, patients, researchers, and others, that we might indeed see a cure for those terrible conditions during my lifetime as a practicing physician. Thank you.
Hi, I'm Bob Listernick. I'm a professor of pediatrics at the Ann and Robert H. Lurie Children's Hospital of Chicago at Northwestern University. We co-founded our NF clinic in 1985, really only a year or two after Dr. Riccardi's seminal article separating NF1 and NF2. So I really got in, I sort of feel at the ground floor. I'm a general academic pediatrician. I'm not I think one of the few in the NF field rather than a geneticist or a neurologist. We were quite fortunate to start at the very beginning with an ophthalmologist in our multidisciplinary clinic, which provided us with the opportunity to really study optic pathway gliomas, which was a big research focus for us. And we're part of the NF DOD Clinical Trials Consortium. Thank you. It really is a true honor to be asked to be part of this great meeting. And now to Danielle.
Good morning, everyone, and welcome. It is such a pleasure to be here with you this morning and with our fantastic lineup of speakers as well. My background is as a clinical cancer genetic counselor, but I have a different reason for being here today. And this is my why. This is Ethan. He is our now 4-year-old who has NF1. And when he was born, he had a cafe au lait spot, like so many of our attendees here today. And I actually have one cafe au lait spot, so I thought that this was like a pretty cool mother-son kind of connection. But by the time he was 3 months old, like many of us have experienced with our children or ourselves, is that he had dozens of these. And so this was no longer a shared connection between us. This was something else and a little bit beyond what I could handle. I needed help. And so I reached out to my colleagues in genetics and we had an evaluation. And over the course of a few years, we got a confirmed diagnosis of NF1. So this is an early picture. He's now 4. He's still got that gleaming smile. He's a happy 4-year-old. And he's experienced some speech delays. He has a few plexiform neurofibromas that we're watching, but overall, he is just a joy to be around. But what we do know is that at some point in his lifetime, he will likely need some of the therapies that are being developed by the NF community. And so we decided this year to jump into some advocacy and some fundraising. And so this is my crew celebrating our very first NF Awareness Month this May. And we did a bit of an advocacy campaign with our family and friends, along with a fundraising campaign for CTF. We got introduced to CTF when he was first diagnosed, trying to find an expert clinic and clinician to follow him. And we have learned so much from CTF and want to support them in any way we can. And so Ethan continues to be my super kid, but we are surrounded today by superheroes, super moms, super dads, super clinicians and researchers and board members and staff and CTF staff members. And we are all doing an amazing job. This is an amazing community. And thank you for being with us here today and spending your day with us. And we know that together we will end NF.
Thank you so much to our wonderful co-chairs. I can tell you from my experience over the last several months that they have been just a pleasure to work with and that we are all equally excited about the programming that we're presenting to you today. So I'm just going to give some instructions for what's about to happen. When you registered, you may have noticed that you had to choose a couple of sessions. So we're going to move now into those sessions. The first thing we're going to do is that if you signed up for the NF1 session, if that is what you want to learn and hear about today, you're going to stay put. You just stay right here with us and you just need to, you don't have to do a thing. If you signed up and you want to be a part of the NF2 and schwannomatosis session, you need to, there's a new link for you to join. It's going to come up on the screen in just a moment here, I know. So these are not traditional breakout rooms for, as you may have experienced in Zoom. Here we go. They are fresh, new Zoom links. This is so that we can offer interpretation services. So if you're staying with NF1, you just stay put, don't do anything. If you're joining NF2, you want to click on the Zoom link or use the meeting ID, and that's going to take you out of this meeting and into the next. Okay, so you'll join that meeting now. You can go ahead and do it. We are going to go ahead and get started with the NF1 general session in this room while everyone is moving into the NF2 room, and I will be monitoring the chat. So if you have difficulty making that transition or you get stuck here and you think you're supposed to be in the other room, please drop a question in the chat and I will be there to help you. So with that, I'm going to hand back over to Dr. Listernick to get us started with our general NF1 session.
Wonderful. Thanks a lot, Kate. Before I introduce Dr. Legis, I just want to ask people, we're going to have a Q&A after each talk. So please put your questions in the chat as we are going. And I will ask Dr. Legis and the various speakers. So first, it's really my distinct honor to introduce Dr. Eric Legis, who's been one of the prime researchers and clinicians in the NF field for years. Dr. Legis is the clinical director of the Center for Human Genetics of the University Hospital of Leuven. His research group has contributed to the understanding of the molecular etiology of tumors and the learning and behavioral difficulties in NF1. I really could go on forever about his accomplishments, but today he's going to talk to us as one of the leaders of the international effort to create a better clinical diagnostic criteria for NF1. Dr. Legis, it's yours.
Okay, now I'm unmuted. I hope you hear me. Thank you very much for this very nice introduction. I'm indeed a clinical geneticist and I'm working at the University of Leuven. And I hope you see my screen now. And I was part of a group that tried to revise the diagnostic criteria for NF1. As you can see here, this represents the world. And everywhere where you have a little star.
Dr. Legis, your screen is not being shared.
Okay. Is it now shared?
Yes, you're great.
Okay. Thank you very much for pointing this out. As you can see on the screen here, all the little stars represent people and centers who collaborated all over the world to try to come up with better diagnostic criteria than before. So we had more than 92 medical specialists divided over 20 countries and 5 continents. And with this group of people, we went through the historic diagnostic criteria and looked very careful at every criterion that was present there to see if we could improve it and also to see if we could add new criteria to make the diagnostic criteria better than they were. So we ended up with this new set of criteria. And as you can see here, the first criterion with 6 or more café au lait spots was not changed. We kept this criterion. Also, freckling in the axillary or inguinal region was kept as it was. 2 or more neurofibromas also. But then the 4th, we just changed it a little bit and we changed it into optic pathway glioma, which is a more appropriate terminology that is used today. The ophthalmologic criterion here with the lesion nodules, there we added that it should be identified by slit lamp examination and that you could also have 2 or more choroidal abnormalities if you use optical coherence tomography, so OCT scanning, which is a new technology that is available now, that was not available at the moment when the previous diagnostic criteria were put together. So we introduced this because this is a very specific finding that together with the lesion nodules constitute a very interesting and good and reliable diagnostic criterion. Then the diagnostic criterion about the osseous lesions, there we changed the tibia into anterolateral bowing of the tibia, which is also more appropriate terminology than we had before. There was a completely new terminology or a new criterion introduced, and that's the heterozygous pathogenic NF1 variant. So we introduced the fact that nowadays NF1 mutation analysis and molecular diagnostics is available. It is not available in every country and it's not available to every person in every country. So we introduced this as a possible criterion, but it is not a necessary criterion. So you can still make a clinical diagnosis without having to, without the need of proving this by a molecular test. So this will make sure that all over the world, where there is a different access towards molecular genetic testing, you still can make a diagnosis of neurofibromatosis type 1, but without molecular testing. And then as the last one, we said if a child of a parent who meets the diagnostic criteria has only one of the criteria above, then this child also fulfills the diagnostic criteria for neurofibromatosis type 2. In the meantime, we know that café au lait macules and freckling can also be present in other conditions, and that it not necessarily always is neurofibromatosis type 1, and therefore we added a note here at the bottom of the table saying that if you have café au lait macules and freckling, these are two separate criteria. And then, of course, you can make the diagnosis of NF1, which is then most likely, but in exceptional cases, it might be another condition. So one always have to keep in mind that if the only features that are present are café au lait macules and freckling, one has to be sure that in the long run, other criteria appear, and then the diagnosis is completely sure, or it might be in rare cases another condition. We also added here that for the pigmentary findings, café au lait macules and freckling, one of the two should be bilateral, because if they are only on one side of the body, it very likely refers or is a sign of segmental neurofibromatosis type 1, which is a mosaic form of the disease. And we really wanted to stress that there's a difference between people who inherit the NF1 variant from one of the parents and have the abnormality in all the cells of their body, or when the mutation happened in the sperm or in the egg cell, then of course at the stage of fertilization, all cells that will be derived from this fertilized egg will also have the NF1 pathogenic variant. But in some cases, the NF1 mutation originates after fertilization and is only present in part of the body, and this can present as a segmental presentation, so on one side of the body or one segment of the body, and not necessarily is affecting the whole body. And so we really wanted to attract attention to that as a separate entity. And then as a last comment, we said if you have a sphenoid wing dysplasia in the orbit of the eye, which is present in association with on the same side an orbital plexiform neurofibroma, then this represents one feature of neurofibromatosis type 1 and counts only once. Here I made a slide to show the multiple café au lait spots, and these new diagnostic criteria are now published, and all these images that you see here represent findings that refer to one of the criteria and are also added to the manuscript. Here you see the freckling in the axilla. These are the cutaneous neurofibromas. These are the choroidal noduli that you see with the OCT scanning of the eye. This is an optic pathway glioma and a chiasma, so an optic nerve chiasma, so it's an optic pathway glioma. Here you have the iris Licht nodules, these brown nodules in the iris. And here you see the bony abnormality. It can be bowing of a long bone of the tibia here. So it's an antero and lateral bowing. It can fracture and then you have a pseudarthrosis. It can be present in the lower limb, so in the leg, or it can be present in the arm. Another skeletal abnormality here is the absence of this fragment of bone, which is called the sphenoid bone at the back of the orbit. And this is this sphenoid bone dysplasia that I mentioned before, which is frequently associated with a plexiform neurofibroma in the orbit. The people from Children's Tumor Foundation, they made this very nice graphic that illustrates all the different aspects of the new diagnostic criteria, including the molecular analysis with the mutation in the NF1 gene, and the fact that it can be genetic, and if a parent has neurofibromatosis type 1 and fulfills the diagnostic criteria, for a child of such a parent, you need only one specific criterion to make the diagnosis. As you can see here in this adult female, you see this nice line here at the middle of the abdomen. And on the left side of the abdomen, you see all pigmentary abnormalities like café au lait spots and freckles. And on the right side, there is nothing to see. So all pigmentary abnormalities in this person were only on the left side of the body. This is the left arm. You see 3 different café au lait spots, and you also see axillary freckling in the left armpit. On the right side of the body, there were no café au lait spots, no freckling, nothing at all. So this is a form of mosaic neurofibromatosis type 1, where the genetic error is only present in part of the body, and in this particular case, only on the left side. And we call this a segmental form of neurofibromatosis, and usually it has a different natural history than the typical neurofibromatosis type 1, which is present in all cells of the body. And that's why we really wanted to attract attention to this. As you can see in this person here, there is one region of the body where you have multiple neurofibromas, but in the rest of the body, there are no café au lait spots or no neurofibromas. So you can have a regional distribution of café au lait spots, a regional distribution of neurofibromas, or you can have a generalized mild form of neurofibromatosis where you see the NF1 abnormality only in part of the cells, not in all cells of the body. And therefore, we also came up with diagnostic criteria for mosaic neurofibromatosis type 1. And they're a little bit more complex and complicated than the classical form. I will not go through them. It's sufficient to say here that we have them, they are there, and it's important that we attract attention to this, because this usually has a different natural history, usually is milder, and it's important to make the difference between classical NF1 and a mosaic form of NF1. So to summarize, the revised criteria for NF1, we included a molecular diagnosis as one of the many criteria, but it is not necessary to make a diagnosis, but it may allow for an earlier diagnosis if you only have café au lait spots. And also by the traditional criteria, you had to wait several years before a second criterion appeared to make a diagnosis. But now with the molecular test, if you can do it early on, it allows you to make a formal diagnosis of neurofibromatosis type 1 at an earlier stage. So diagnosis based on clinical findings is still possible. There are footnotes on the presence of café au lait macules and freckling as only criteria. And then the doctor has to make sure that it's not anything else, or has to keep in the back of his mind that it might be something else in a rare case. And also a footnote on the combination of sphenoid wing dysplasia and orbital plexiform neurofibroma, because in a rare case, these two things happen together without any other physical findings of neurofibromatosis type 1. And then we are probably in the situation of mosaic NF1. So we gave special attention to the mosaic form of neurofibromatosis type 1. And at this moment, diagnostic criteria for neurofibromatosis type 2 and schwannomatosis are near final. The manuscript is being prepared and it will be submitted soon for publication. And then we will see what the peer review will say and if it will be published or not. But this is a more complex story, and we probably can come back on this next year.
Wonderful. Thank you, Dr. Legis, for such a clear talk. We have a few minutes for questions. The first question in the chat really is, you mentioned other conditions with cafe au lait spots. Can you elaborate a little bit about that?
Yes, one of the other conditions that is the most frequent in 3 to 4% of all children with multiple cafe au lait spots, the genetic error is not in the NF1 gene, but in the SPRED1 gene. And this is a condition that we reported for the first time in 2007 and has been given the name of Legis syndrome or Legis syndrome. These children, as adults, never develop the tumoral complications. So they never develop neurofibromas, they don't develop optic pathway gliomas, and the other things that you see in NF1 regarding tumor formation. So it is important to recognize it, but from the clinical point of view, it is impossible to make the distinction between a mild form of NF1 and Legis syndrome, and therefore you really need molecular testing to differentiate the two. If it's a familial form of NF1, and if one of the members in the family has some additional findings, such as a tumor, a plexiform, or a cutaneous neurofibroma, then you can exclude Legis syndrome for sure. There are a few other much rarer conditions, but it's probably going to take too long to mention all these. Yeah.
Great, thank you. The next question in the chat is, somebody's asking that my neurofibromas are on the outside, but my brothers are on the inside. Why the difference?
Yes, we know that even within the same family, where relatives have the same genetic error, that you can see a big difference in how the disease is manifesting itself. So we call this a variable expression. We know that in order to get a tumor, you need to acquire a little mistake in the normal copy of the normal NF1 gene. And this is something that just happens during life, and that's very difficult to predict. And in some individuals, this happens on the inside of the body. In other individuals, it happens more on the outside of the body. And these are things that are not related to the NF1 error itself, but due to the second hits in the normal copy of the NF1 gene. And this is very unpredictable. That's why the disease itself is quite unpredictable in general, and the variation is so large.
Wonderful. You know what? I think we're right out of time. So thank you very much, Dr. Legis. There's 1 or 2 questions in the chat. If you don't mind answering them in the chat after we move on, that would be great. For this next part of this session, the organizers felt it would be really helpful for the audience to hear some of the wonderful poster and platform talks given in the recent CTF meeting. So we've chosen 3 excellent ones, and I will introduce each of these speakers. They're going to present for about 7 minutes, and then we'll have a couple of minutes for questions if there are any. So our first speaker is Dr. Frank Bono, who is an associate research scientist in psychiatry at the Yale University School of Medicine. I know that Dr. Buono has had a long-standing interest in the management of pain, and his poster is entitled "The Qualitative Understanding of Pain Interests Across Medical Experts and Individuals with NF1." Dr. Buono, please go right ahead.
Thank you so much, Dr. Listernick, for the nice introduction. I'm going to share my screen now. Can everyone see it? Yeah. Okay. So once again, thank you so much. I am an associate research scientist in the Department of Psychiatry at Yale. Just want to provide an understanding of what we're doing in my research lab, and I think this is a great clinical approach to helping individuals with pain suffering from NF1. I do have no disclosures to report this time. As we know, about 50% of all adult individuals with NF are reporting significant pain and discomfort. And of the 50, and in the new published research just showed 70% of individuals with NF are suffering from some form of pain. Given that, there are potential barriers for individuals with NF who are suffering from that pain. Specifically the difficulty in assessing those needs, specifically during COVID even, and limited availability of trained professionals such as psychologists to particularly in non-urban areas. So in those rural areas or not areas that are not available for NF services or not have good NFOs, it's very difficult to find any help. And then there's limited access to self-management techniques. Be that as it may, mobile health applications can only increase access to pain management resources, but they are also able to be tailored to specific needs of the specific illness or conditions. So what we did was we are proposed to adapt a pre-existing platform, mobile application for adults with NF1 by interviewing adults with NF1 and medical experts. Just to show you what we have, this is the I Can Cope mobile application. It is currently in the clinical trial. This comes out of was developed by Jen Stinson and her lab at University of Toronto. If you want to talk more about this, about the mobile application, I'm more than happy to talk to you online or offline about this as well. So what we did is we recruited 32 individuals with NF1 who were adults, and we had 10 experts who had experience with NF. Each of these groups, we had about 4 to 6 individuals in the patient group and about 2 to 3 in the expert group, joined a focus group for about an hour and talked about 4 different domains regarding the research about what would be useful for a pain app. As you can see, 25 of them, of the 32 were female. Most of the individuals had some form of pain, and we marked it by looking at the pain severity and pain interference, and that was at 0 out of 10. So there is moderate level of pain for all of them. If you look quickly at the bottom of the screen, you see for the years of experience, we had a lot of individuals who were in the expert group were very seasoned at the average of 19.2 years to have actually seen clients. So very quickly, I want to just talk about the themes that we had here. It broke down to 2 domains, the individual level and the app level. And within that, there were 6 themes that emerged. The first was lifestyle within the individual. The second were reasons for using, and third were concerns. And then within the app level, it would look at desired content, desired features, and format consideration, and taking into account to what we found. And in doing our analysis, which is currently being evaluated for publication as we speak, we noticed that if these were met, there was a higher level of motivation of use and or reuse to the mobile application, which is something very importantly needed for individuals who are using mobile applications. I want to just focus really quickly on some selected quotes One would be from the pain expert group. We had an emphasis saying that there was plenty of research out there about pain education, but when it talks about pain education for NF, it's far from lacking. And so what we did in the mobile application based on this criteria was add a pain education subsection for individuals who have been in the clinical trial. And the desired features section, I think this is very important. 31 of the 32 individuals talked about this area, saying that they rarely had met someone prior to being diagnosed or after being diagnosed with NF, having access to individuals to talk to about their disease, to be able to be hopeful for coping with that disease. And so having a community is very critical. And that is something that we have taken into consideration when developing the mobile application. Because I'm short on time, I want to just skip ahead really quickly. Both groups were very enthusiastic about the mobile application and the ability to accommodate individuals with NF1 across their lifestyle and by incentivizing the use of it. This is very actually interesting and what my group has found very interesting. The two groups had different views on the relevance of pain management and what was important in tracking. The NF group was more interested in looking at the detailed and nuanced pain information. Was it the pain numb, tingling, numb feeling, radiating pain? Where was the pain located? Did it spread? Did it not spread? While the expert group was more interested in tracking the associations with pain to mood, to the nutrition, to physical activity, to sleep, and that was something that we found very interesting. And then of note, it was very important that the mobile application be easy to use, convenient, and modifiable in a user's lifestyle change. For that, I want to just thank my funding agency with the CDMRP. I also want to thank my team members at Yale School of Medicine, the Connecticut Children's Hospital, and the Hospital of Sick Children. And I really do thank you for the time and the opportunity to present. I am more than happy to answer any questions if you have any.
Thank you, Dr. Bono, for that great talk and that really interesting app that you're creating. There's one question in the chat, and I have a question. Good luck with this question. How do you define pain? The chat's asking, is it a burning or throbbing sensation? Go for it.
Yeah, so that is a question that actually we can talk about for about 5 hours if you really wanted to, but it's pain to everyone is a personal event. And so what pain might be for me might be completely subjective for myself, but it's going to be different for the person who asked the question. So, it's important to track your pain, important to understand your pain, and it's important to talk to your doctors about pain.
Thank you. I have a question. Did the NF group talk about how their physicians don't really know how to treat their pain? I mean, I'm speaking as a physician who really in medical school was not trained at all in pain relief.
Sure.
Zero. Of course.
Yeah. I would point out, Dr. Listernick, that age is just a number, first off. And the second is that is a reoccurring theme that we found that most of the individuals that we interviewed, they said the focus question was, rate your pain on a 0 to 10 scale. And they would rate the scale in a very subjective way. And then they would say, that'd be it, that there would be no other follow-up questions to that. So there is a disparity of pain and how to deal with it within the department, neurology and whatnot. And so there is a need for a multidisciplinary clinic to encapsulate pain within any NF clinic.
Thank you. I don't see any questions. Well, I guess I'll ask another one. Where do you see this app going? How is it going to? How are people going to use it? How is it going to function?
Fantastic, thank you. Yeah, so currently we're in the clinical trial right now, and we are looking at the initial efficacy of this. We are just putting out a new grant to focus on adolescent pain, and with this mobile application. And so I think that if the initial efficacy comes through, I think we want to open the app up for everyone so that they can track and monitor their own pain. And I'm always happy to talk about this more. If you have a question or anyone has a question, you can send an email to me. I'm always available.
Well, I guess we have a couple more minutes and I don't see other questions, so I'll ask another one. Is adolescent pain different from adult pain, or child pain different from adolescent pain?
And it is. And to be honest, the child and adolescent pain, they're more bluntly honest than adults are with their pain. They can pinpoint their pain and say, "Oh, it is my leg. It hurts. It doesn't feel right," and they're generally more spot on with their pain symptoms than adults, because adults generally deflect, diffuse, and think about it as some other covariate. But yeah, there is a large difference from the pain.
That's really interesting. I think we'll stop there. Dr. Bono, maybe you can stay on for a few minutes, and if there's any other questions, you can answer them in the chat. Okay?
Definitely. Thank you so much for the time.
It is a pure delight to introduce our next speaker, Dr. Andrea Gross. Dr. Gross is an assistant research physician at the National Cancer Institute. She's a pediatric oncologist who focuses on clinical trials research in tumor predisposition syndromes such as NF1. Dr. Gross is really on the cutting edge of almost every aspect of clinical research in NF1. So if she doesn't know it, it doesn't exist. And her talk today is going to be entitled Long-Term Safety and Efficacy of Selumetinib in Children with NF1. And I should mention that she'll be doing double duty later on in another talk in a different session. You're all yours, Dr. Gross.
Thank you so much for the very, very kind introduction. And thank you to the organizers for inviting me. I'm really excited to be here today. So as Dr. Listernick said, I'm really happy to have the opportunity to present to you what I presented at the CTF conference a few weeks ago, which is an update on our phase 2 study of selumetinib for children with NF1 and inoperable plexiform neurofibromas, which also goes by the name the SPRINT trial. Okay, hopefully I can, there we go. So as some of you in the audience may be aware, we published the results of the selumetinib trial, phase 2 trial of selumetinib in pediatric patients with inoperable plexiform neurofibromas about a year ago. And the data cutoff, meaning the time at which we stopped collecting data for the publication, was March of 2019. Now, because of the patients still continuing to have benefit, at the time of data cutoff, there were many patients who were actually still on treatment. And so, overall, we enrolled 50 patients on the study. The duration of treatment at the time of that data cutoff was 36 cycles. And the best response we saw in terms of volume was minus 27.9% in how much the plexiform shrank. But the time to best response was about 16 cycles. And I apologize because I think I actually accidentally double-clicked through my first slide, which was a little bit of more background, meant to be more background on what a plexiform neurofibroma is. Though again, I think this group is very familiar with this, which is these are not cancers, but they are benign, and I use that in quotes, tumors that can be quite large, grow along any nerve in the body, and can cause lots of problems. Again, I think a lot of people in this group already know, depending on their location, they can cause disfigurement, they can cause pain, they can cause difficulties with function like breathing or bowel or bladder function, and they can, in some rare cases, but significant, be life-threatening. Also, we know that there's a risk over the course of one's lifetime in about 10 to 15% of patients for these benign tumors to become highly aggressive cancers. And as you can see in this picture here, these tumors grow over time. This 3-year-old has a tumor in his neck and arm that grew significantly between ages 3 and 5. What we're looking at here is an MRI of that same patient. The tumor is all the stuff that's white here. I'm not sure if you can see my mouse, but that got significantly larger at 5 years of age. And what you can imagine here is surgical removal of this whole tumor is really not possible. It's not feasible to take out this whole tumor. And so until recently, there really were no effective medical therapies, which again leads us to the results of the selumetinib trial, which we presented several years ago, which was very exciting because it showed that in more than half, in about nearly 70% of patients, 34 of the 50 patients had what we call the confirmed partial response, which meant more than 20% shrinkage of their tumor from baseline, and that most of these responses, over 50%, were durable or lasting more than 1 year. But again, at the time of this publication, 29 subjects still remained on treatment. And so we wanted to see, okay, what's happened in the last 2 years and do we have any more information? And so that's what we're presenting today. It's the same study. We're just presenting additional data on the patients that have remained on treatment. So now when we look at all of the patients 2 years later, the median duration of treatment is 52.5 cycles. And for our study, a cycle was 28 days or about a month, because patients receive drug every day, continuously, twice a day of the selumetinib, because that's how it's dosed. So if you see the word cycle, that basically means month. 23 of the subjects at our new data cutoff, which is just this past February 2021, are still on treatment. So that's out of our 50 total subjects. Interestingly, you'll see the best response of minus 27.9% and the time to get to that hasn't changed at all, which indicates to us that the patients that are achieving a response are doing it early on and generally are not having increased additional dramatic responses beyond the first year or two of treatment. Again, similar to what I was saying a minute ago, the confirmed partial response rate has not changed. It was still 68%. So no additional patients had a new partial response after our first data cutoff. I'm not going to go through this in detail, but this is just a table showing the reasons. There are 27 subjects of the 50, obviously, who are not on treatment anymore. And these are the reasons that they came off treatment, with the most common being progressive disease, but a whole variety of other issues. This is what we call a waterfall plot. This takes a look at each individual patient's response. And what you can see here in blue is their best response, so the most shrinkage they had at any time on the study. And in black, next to that is that patient's response at the time of data cutoff, at the last time they had a restaging evaluation or an MRI evaluation before data cutoff. So the blue is what you can see here. We did have some patients now getting down all the way to 60% shrinkage as best response. But again, we didn't have anyone who wasn't a responder in the previous data cutoff who's a new responder now. The other thing you can see is that at data cutoff, we did have subjects that had disease progression. But what's notable is that you can see only one patient. We defined progression in two ways. One patient had progression by having growth more than 20% above their baseline. The other way we define progression, which applies to all these other red stars, is you can see they had a big jump from their best response to their most recent. Their best response was really good, and then they got bigger. And so they had a more than 20% increase from their best response, but many, if not most of these, were actually still at or below their baseline volume. So it's just important to note that even though they had quote unquote disease progression, many were still had tumor shrinkage from where they started. Also, of the 11 the patients that had progressive disease, 8 had a dose reduction prior to disease progression, which makes us really strongly think that maintaining the dose that is prescribed and staying on the medication is necessary to maintain a response. One thing that was also important in the original publication was that we found an improvement in plexiform neurofibroma-related pain when patients were treated on selumetinib in this study. And that was seen significantly after a year. And so now we looked after 4 years on treatment before their 49th cycle or 49 months of treatment. And what we found is that improvement in pain, as measured on that 0 to 10 pain scale that Dr. Bono was just talking about, was maintained. So this was their baseline pain, which is a little above 2. The lower the number, the better on that pain scale. And in this case, we were able to show that the pain improvement we saw after a year was basically the same after 4 years. And we saw similar things for the improvement in the pain interference index, which is another measurement of pain. One of the other things we really were interested in looking at a new data cutoff for this data was safety. Because now we've had these patients and subjects on treatment for an additional 2 years, and we wanted to see, were we detecting any new safety signals? And so what we found is no. The vast majority of patients, and if any of you have been on Mech Inhibitor or know people on Mech Inhibitor, you know that most patients will have some side effects, but most of them are mild, and all of them were reversible. Most patients had either a stomach related side effect or adverse event is what we call it in clinical trial, like vomiting, nausea, or diarrhea, or a rash. A lot of patients had asymptomatic lab abnormalities or a nail infection, which is what I'm showing here. This is called paronychia. This is called paronychia, this rash, this nail infection around the toenail. This rash you can see on the patient's back is very common. It's an acne type rash that we often see in our patients on the Mech inhibitor. We also had patients who had asymptomatic abnormal findings on the echocardiogram, which looks at how well the heart is squeezing. That is a known effect of Mech inhibitors, and it's one of the reasons that we monitor both the heart and the eye so carefully while patients are on Mech inhibitors, that we do see these changes. But again, in all of our subjects, they were asymptomatic and they were without symptoms, which is what asymptomatic means, but they were also reversible. And then again, one of the other potentially serious side effects of Mech inhibitors are eye, or the back of the eye, called the Retina related problems. And we did not see that in any of our subjects. But again, even without that, most patients did have at least one adverse event, and many, 17 of our subjects, required a dose reduction for their adverse events, and 5 actually came off of treatment because of toxicity. So clearly, selumetinib, we're really excited about what it can do, but it also has limitations and is certainly not a perfect solution. It's not getting rid of the tumors altogether. The best shrinkage we're seeing is 60% from baseline, and it does have side effects. So, just kind of emphasizes the need for studying additional treatments and options moving forward. So just to summarize, what we found when we looked at 2 additional years of data on the phase 2 study of selumetinib, or SPRINT, in children with plexiform neurofibromas is that for many subjects, we maintained clinical benefit at data cutoff, including a volume response. Most of those who had a partial response continued to have it at the time of the new data cutoff, and including improvement in pain. Importantly, that we saw continued improvement in PN-related pain compared to baseline. We didn't see any significant additional volume reduction after the first 2 years of treatment. There were some patients that had a small amount of additional volume reduction, but overall as a group, we saw the volume, whatever volume reduction you were going to achieve usually happen within the first couple of years. And then patients had plateauing or stabilization of their tumor volume. We also didn't identify any new long-term safety or toxicity signals. And but it is important to note that, as I said, there's still 23 patients on treatment, and even the patients off treatment are still being followed for long-term safety, and we're still continuing to analyze this data. So we will hopefully be able to come back in a couple of years with even more information. Before I finish, I would just like to thank all of the patients and families who participated on all of our clinical trials, but in particular the SPRINT trial. It was a very labor-intensive clinical trial for patients and families to participate in, with lots of evaluations. And so we're just so grateful to everyone who did so. Of course, I'd also like to thank Dr. Wiedemann, who is the principal investigator of the study and who I've worked with at the Pediatric Oncology Branch, and then the entire team at the Pediatric Oncology Branch, NF team, Dr. Pam Walters, who led our patient-reported outcome measures. And then, as you can see listed here, this was a multi-site study led by some of the speakers you're going to hear from on other sessions later today, Dr. Spisher, Dr. Weiss, Dr. Kim, Dr. Bornhurst, and Dr. Blakely. So just thanks to everyone, and thanks to our those who supported our funding, including NTAP and the Children's Tumor Foundation. And with that, I'm happy to take questions. Hopefully I didn't run too much over time. Sorry.
Well, thank you, Dr. Gross, for that great talk. We really are at the end of the talk, but I'm going to ask one question that was in the chat. If you could answer briefly, if the patients get off the meds after showing a good reduction, did the tumors grow back?
I'm not sure if you can still hear me. My computer just seems to have frozen.
I can hear you. Your video.
Okay, that's fine. So repeat the question. If the patient stop the medication, do the tumors grow back?
Yes. You know what? Why don't you answer in the chat, Dr. Gross, where I think we're having a hard time with you. Don't worry. No
I
problem.
apologize.
No
My
problem.
screen just froze.
Why don't you answer in the chat and we'll move on. So our last talk of the session, of this poster session, is by Dr. Jonathan Meachin. He is a pediatric neuropsychologist and an assistant professor in the Department of Neurology at University of Wisconsin School of Medicine and Public Health. Dr. Meachin specializes in cognitive and neuropsychological evaluations for children and adolescents with a broad spectrum of medical disorders, developmental delay, and academic challenges. His talk is entitled "The Utility of Neuropsychological Screening in a Multidisciplinary Neurocutaneous Clinic." Thank you, Dr. Meachin.
Yeah, thank you for that introduction. It's a pleasure to be with you all today. I'm just going to take control here of this of the slides here. Okay. So yeah, today I'll be talking about our findings from our pilot study that looked at whether neuropsychological screening can be helpful within a multidisciplinary NF1 clinic, particularly in kids. So kids with NF1 can sometimes have cognitive deficits that affect their thinking and learning. And these deficits sometimes include things like poor attention, memory, problem solving, or judgment. Neuropsychologists are usually the ones who can evaluate for these deficits and give the recommendations needed to help treat, manage, or accommodate for such deficits. There are several ways that neuropsychologists do this for patients with NF1. And as you'll see here, this is a model or a method that's been proposed and has gained some support. So medical providers can help identify if a patient needs to see a neuropsychologist. Then the neuropsychologist conducts either a screening evaluation, a targeted evaluation, or a comprehensive evaluation. And then follow-up monitoring continues after that evaluation to see if or when that child might need to see a neuropsychologist again. So for our specific study, it involved the screening assessment to see if such a screening assessment can be done within a multidisciplinary clinic, to see if it can identify cognitive deficits, and see if there's a screening method that can help the neuropsychologist make clear and accurate diagnoses. All right, so what does a day in our clinic look like? The cognitive screening takes place in the morning before the child sees their multidisciplinary team in the afternoon. Our screening includes the clinical interview, brief intelligence test, the NIH toolbox, and questionnaires that help us understand the child's emotions and behaviors at home. The NIH toolbox is a group of tests that are given on an iPad with the help of a psychometrist, which is a person that's trained to administer such tests. And the tests on the toolbox measure different cognitive and thinking skills that include things like attention and focus, processing speed, multitasking, sequencing memory, and working memory. For those unfamiliar with working memory, I think we can kind of think of it as a little sticky note for our brain. It helps us hold new information in place so that our brains can kind of work with it. And then we can kind of throw that information out once we've used it and we're done with it. After the child is seen in the multidisciplinary clinic, after testing, the child will then be seen in the multidisciplinary clinic where they meet with other providers like oncologists, neurologists, rehabilitation doctors. And it's during this visit, this afternoon visit, that they'll receive results from their testing earlier that day. And in this sample, we had 17 participants. About half were male and half were female. Ages ranged from 5 to 19, but the average age was 9 years old. So what were our results? Our testing in this screening clinic could be completed in under an hour. On average, it took 53 minutes. This is much shorter than a comprehensive evaluation takes and is short enough that it can be considered a screening assessment. What about new diagnoses? A new diagnosis means that screening found a diagnosis that the child had not ever received before the screening. So on average, this screening evaluation helps to find 1 to 2 new diagnoses. 11% had a new diagnosis of mood disorder. 17% had a new diagnosis of ADHD as a result of the screening. 23% had a new diagnosis of anxiety. 23.5% had a new diagnosis of intellectual disability. And 29% had a new diagnosis of mild neurocognitive disorder, with 29% having a new diagnosis of major neurocognitive disorder. The screening test could also identify cognitive weaknesses or deficits when they were present for these kids. So as we can see here, children in our sample had lower than average performance on an IQ test. This included overall IQ, as well as verbal IQ and nonverbal IQ. The average range is the section that's shaded in orange, and as we can see, their average performance was slightly below that. Again, on this slide, the average range is the section shaded in orange. And on the NIH toolbox, so if you remember, that's the tests that are given on the iPad. Kids in our sample had lower than average performance on each test here, including attention and focus, working memory, which if you remember, that's kind of the mental sticky note, processing speed, multitasking, and sequence memory. Their overall combined score was also quite a bit lower than average as well. We also wanted to know if this screening could help us identify kids who needed additional follow-up, and if the screening could help us give targeted recommendations for each individual child. So about 65% needed neuropsychological follow-up. It was recommended that they have neuropsychological follow-up in the future. And the median recommended time for follow-up was 1 to 2 years after this screening evaluation. About 70% needed recommendations to help them in school, and about 65% needed some form of mental health recommendation for things like mood disorder, anxiety, or ADHD. So one thing that's important to keep in mind is that these findings don't represent all children with NF1. The children seen in our screening clinic were children who had already been identified as a child who should see a neuropsychologist for one reason or another. So are these findings important? Well, first, our screening identified cognitive weaknesses and helped with treatment planning for children with NF. These patients had quicker access to neuropsychologists and neuropsychological services. Testing was shorter, but we could still help to find and diagnose some disorders that would require treatment. And finally, because this was done as part of a multidisciplinary clinic, there was better teamwork and collaboration between the neuropsychologist and other medical providers. Here's the references. Thank you, and I can take any questions.
Thank you, Dr. Meechan. I think we have time for one question. Someone asked whether adults can undergo this testing, and I'll add, should they undergo this type of testing?
Yeah, yep. So it probably wouldn't be the exact same test that we provided here, but certainly there are adult neuropsychologists. And so if you find that you're having concerns about your memory or attention, as an adult, I think it's worthwhile to talk to like a primary care provider and ask if they know of any adult neuropsychologists that can provide that testing. But yes, this testing is available for adults as well.
Okay, and the next question is, would it specifically help with diagnosing dyslexia or autism?
So neuropsychological evaluations do. I think this screening clinic would be an opportunity to kind of discuss those concerns, and then from there we would determine if additional follow-up testing would be needed. And for those where that would take place much sooner than that 1 to 2 year.
Okay, so at the chat has exploded with several questions, but I do have to move on. Dr. Meehan, if you don't mind staying on and answering these questions in the chat, we'd all very appreciate it. Thank you. So for the last talk in this particular session, I'm really pleased to introduce Dr. Miriam Bornhurst. One of the many problems in this pandemic is that we as NF research didn't get to collaborate, meet, chat with our NF friends over directly, and so it's great to see Dr. Bornhurst here. Dr. Miriam Bornhurst is a pediatric neuro-oncologist at the Children's National Medical Center, and she's the clinical director of the Gilbert Neurofibromatosis Institute. Her talk is entitled Selumetinib, Current and Future Uses. It's all yours, Dr. Bornhurst.
Great, thank you very much. Let's see if I can go ahead and take over the screen here. All right, as Dr. Listernick said, I am the clinical director of the Gilbert Family Neurofibromatosis Clinic here in Washington, D.C. I also work with kids in general who have cancer predisposition, but neurofibromatosis type 1 is my primary specialty. Today, I'm going to talk about Closed, but I will also talk about a few other Mech inhibitors because they are all sort of being explored for the use of the treatment of tumors and potentially other things in neurofibromatosis type 1. I do have to just briefly disclose I was a consultant for AstraZeneca until February of 2020, and so primarily talking about Plexiform Neurofibromas and the approval of this particular medication, but not doing that anymore. Okay. So some of the questions that I'm hoping to address today: what treatments are available for my child? Are there treatments available for adults? What do you know about that new medication that was just approved for NF? Should my child start treatment with a Mech inhibitor? And what research progress is being made in the field? In order to really understand Closed and Mech inhibitors and how they work, what we first need to talk about is how do tumors form, or how is it that tumors develop in a person who has NF1. So NF1 gene is a tumor suppressor gene, and basically what that means is it's very important for regulating cell division. So in your body, you always have cells that are trying to divide, and sometimes it's good for them to divide. For example, your skin cells or your cells in your cheek, you want them to divide so that you can replace cells that have sloughed off. But there are other cells that you really don't want to divide, and those include cells that are in your brain or along the nerves in your body. And so NF1 is there to tell those cells, now is not a good time for you to divide. But sometimes what can happen then, so here you have inside the cell, there's always a pathway or a signaling pathway. So the signal comes to try to tell the cell to divide, and NF1 has to do its job. So if you have a signal that comes, the signal will come in, and if NF1 is working, or so if it's active, in its active phase, then essentially what happens is it actually stops this pathway and you don't have a change in the cell. So the cell does not grow or change or divide. But what can happen is if you have a signal that comes and the NF1 gene is not doing its job the way that it needs to be doing its job, the pathway can be active at a time that it's not supposed to be active necessarily, or at a time that it is supposed to be active, and you'll have cell growth and division. So NF1 is caused by a spelling error in the NF1 gene that affects its function. And so it makes it so that it's more likely, these signals are more likely to get through and those cells are more likely to divide. Tumors form when the second gene is also affected. So with NF1, you're born with one copy that's affected. As long as there's only one copy that's affected, then cells will be okay. It actually can have normal function. But if you have an area where you have one cell or one gene that's affected, and then the second gene is also affected, so both copies are losing or decreased function, that's where you can get cell overgrowth. And where this happens in the body determines what type of tumor you're going to get. If that happens in your optic nerves, you can get an optic pathway glioma. If it happens in your peripheral nerves, you can get a neurofibroma. If it happens along the skin areas, you can get a cutaneous neurofibroma. We even know that cafe au lait spots can be affected by that second hit or that second loss. And there's some GI and some brain abnormalities as well that are caused by that. So what then are Mech inhibitors? What are these treatments that Dr. Gross just talked about or that you've been hearing about for the treatment of tumors in NF1? These are some of the examples of Mech inhibitors. So there's the Closed, which is the one that I'll focus on most today. Selumetinib is another name for it. Binimetinib, Mekinist, Cobimetinib, and Mirdametinib are the primary ones that have been explored in NF. These act by inhibiting the Mech protein, which is part of that RAS-MAP kinase pathway in the cell that helps with cell division. So if we look at that picture that I showed you already, here we have a signal again. If NF1 is not able to do its job, but we give a Mech inhibitor, then what it does is it actually inhibits here instead. So the signal will get to a certain point, but now we inhibit the signal here instead of up here. And then you have decreased cell growth, and sometimes you can even have cell death, because this can also sometimes tell cells that were abnormally growing that they're not supposed to be there, and they will have cell death, which is how the tumors can sometimes shrink as well. So how can you get treatment with a Mech inhibitor? Right now, there's two ways that you can get treatment. One of them would be through insurance. So selumetinib, or again, the Closed, is the best way to do that through insurance. There are some off-label ways of getting it too if needed. And then clinical trials. So a lot of these trials are actually closed right now, but there is still one that's open. This, the PD0325901 or Mirdametinib is open for children and adults. The adult phase is actually closed recently, but the children, it's still open for children. So what is Closed? So this is the first ever FDA-approved medication with an NF indication, which is very exciting. Plexiform, it's primarily indicated for plexiform neurofibromas with associated morbidity. And they know that, or we know with this, that there's a phase 2 study, which actually Dr. Gross showed you, that all patients but 2 had shrinkage of their tumor. It also helps with other aspects of the tumor. So it helps with quality of life, it helps with pain, as Dr. Gross had mentioned as well. It helps with the risk for tumor progression. So this is something that was published with the data for this study in the New England Journal of Medicine that shows, for their normal progression of a neurofibroma, so natural history, what you would expect to see over a 3-year period of time, but then what you see with the selumetinib treatment. So it's definitely, or the Closed treatment, so it's definitely decreased in patients who are taking medication. And then this is just another way of looking at the way that it helps with tumor shrinkage. So this was actually the phase 1 study. So you can look at different doses of the medication, and with all of the different doses that we tried, there has been shrinkage or shown to be shrinkage of the tumor size. This is the primary dose that we use, is 25 milligrams per meter squared. But even if you're having side effects and you need a dose reduction, it is helpful to know that you can still see shrinkage of your tumor. The farther or the longer this bar is, the more shrinkage there is. So this patient had close to 50% shrinkage compared to this person who had somewhere around 5% shrinkage. So who should go on treatment with the Mech inhibitor or Closed? Right now, it's indicated for patients who have progressive or growing plexiform neurofibromas. It's also indicated for patients who are symptomatic. And I would say one major exception here would be patients who have the potential for severe medical complications if the tumor is not treated immediately. So an example on that, for example, would be rapid vision loss for an optic nerve tumor or for a plexiform neurofibroma that could potentially affect the optic nerve, or spinal cord compression. And sometimes for these tumors, surgery is actually better than treatment with a Mech inhibitor. Tumors that have the potential to cause significant issues can also be treated. So if you have a tumor, for example, that's about ready to grow along the spinal cord, but is not quite causing problems yet, that could potentially be treated with this medication. And it's also for tumors that are formed during childhood. So there's a lot of questions that I saw in the chat about, can this be used in adults? And we are looking at it in adults, but right now the primary indication is for tumors that form during childhood. And this is just an example of what you can see. So here's a tumor. So this is showing the tumor here. So this is the patient's teeth up here. And then we're kind of looking through a cut through this direction. So the ears would be on the side right here. This is the back of the head. This is the tumor right here. And this is where the airway and the esophagus are. So you can see that the tumor is really affecting this patient's airway. And here you can also see this is where the airway would come down and the tumor is pushing up against the airway. After treatment and after the tumor decreased in size, you can see that the airway is opening up. The tumor is kind of moving or shifting per se in the shrinkage. And then here you could also see that the airway is more open. So even though this patient didn't have a huge dramatic decrease in the tumor size, quality of life was significantly improved because of the effect or the decreased effect of that tumor on the airway. Dr. Gross already went over the side effects, so I won't have to go over this very long, but there are some side effects definitely with this medication. There's common side effects, and then there's potentially serious side effects. And so if you are treated with a Mech inhibitor, you do have to be followed very closely by a physician who knows the side effects and knows what to watch for. The acneiform rash is the one that is most common, particularly in adolescents and young adults who are on this medication. You can have a lot of different GI symptoms, lack of energy. Sometimes you can have muscle or bone pain at the beginning that eventually goes away. You can get mouth sores, headaches. We showed the paronychia, itching. So I have a number of patients who are on this medication who have increased itching along with dry skin. And then again, some of the GI effects. And then swelling is something else you can see. The swelling is mostly in the fingers and the toes, but I've also seen swelling underneath the eyes or sometimes in the face. The potentially serious side effects, again, include eye toxicity, so you need to make sure your eyes are being watched very closely while you're on treatment. This has been reported more so in adults than kids, but it is something that we have to watch for. Decreased heart function, again, is something that's reversible, but we do want to capture it before it gets to a point where it's potentially not reversible. And then there can be abnormalities in the liver and muscle weakness. And the muscle weakness can actually get to the point where people have difficulty walking or moving. So that's something, too, that we'd want to keep a close eye on. And this is just pictures that I found online, very similar to pictures that I have from my patients showing sort of the acneiform rash as well as the paronychia that can come and that we would need to treat if we find this. So this is where Koselugo is now. What about the future of Koselugo and other Mech inhibitors? Where is this going to go in the future? One of the things that we're looking at actively would be the treatment of low-grade gliomas with this medication. So with NF1, as I showed you, the plexiform neurofibromas will form when you have upregulation of that particular pathway. The same thing happens if you have a low-grade glioma. So these are also cells that are abnormally growing and should respond similarly to this medication. So there are a number of clinical trials that have been looking at this. You can see, again, that a lot of them are now close to enrollment. So hopefully we'll be able to get some really good data out of that that'll help with the approval of this medication for treatment of low grades. There is one now looking at this particular medication compared to the standard chemotherapy, so carboplatin and vincristine. So this will also be a very interesting trial where we're hoping to see, is one better than the other one? Should we do chemotherapy first still and use this as second line, or should we actually go to the Mech inhibitor for first line for treatment of gliomas in children? And this is just showing, again, so low-grade gliomas, there's the PBTC-029 study. The data has already been published. And so stratum 3 was the one for patients with NF1. Stratum 1 were patients without NF1. And you can see that with the patients who did not and did have NF1, they had a similar response. And this is just sort of an example of how the tumor can shrink or change when you're on treatment with a Mech inhibitor. Other clinical trials that are available, so there's been some discussion about using selumetinib or Koselugo for patients who have cutaneous neurofibromas. This was primarily out of the University of Alabama and the NIH, and hopefully we'll be getting some data released from this as well. And then there are also some people, and I didn't put this on here, but there are people looking at topical formations of Mech inhibitors so that instead of having to swallow a pill every day, you can actually apply a cream potentially to see if that helps with the cutaneous neurofibromas. Again, something that's in research right now. Mech inhibitor trials for adults with plexiform neurofibromas. So some of these are closed, like binimetinib, NF108 is closed. The NIH study may or may not be closed. I have to apologize. I'm not sure the status on that one. I think it might still be enrolling. But mirdametinib, or the PD03259101, is definitely still enrolling through SpringWorks. And so this is a way that you could potentially try a Mech inhibitor for plexiform neurofibroma if you're sorry, this actually, it did just close for adults, so for kids, but not for adults. And then you have the Mech inhibitor trials for children with leukemia. So there are a small number of patients with NF1 who will develop a specific type of leukemia, this JMML. And the thought with this is that if these is formed the same way, you could potentially use a Mech inhibitor. So for young children with this leukemia, they're using trametinib now to see if that helps. Research progress of other things that we're looking at. So combination therapy. Would it work better if we put a Mech inhibitor with something else? So if we took a Mech inhibitor plus cabozantinib, for example, which is a tyrosine kinase inhibitor, which inhibits signals at the very start when it hits the cell, or a Mech inhibitor plus an mTOR inhibitor, which is another pathway in the cell that sometimes can actually be very similar in terms of their action. We're looking at differences in treatment schedules. Right now, if you go on treatment with a Mech inhibitor, you take it twice a day, every single day. But is it possible that having different treatment schedules would be better? For example, for the mirdametinib study, they're doing 3 weeks on, 1 week off. Or are there other ways you could do this? 5 days on during the week, 2 days off on the weekend, to see if that helps with response as well as with toxicity. And then here, supplemental therapies. So we know that the Mech inhibitors can be very helpful, but one of the things that we don't know is how to best help with the side effects that come with the Mech inhibitors, but also how can you use other types of diet and metabolic therapies to help enhance those responses. And so when you're on a Mech inhibitor, sometimes you can have weight gain, for example. Are there ways that we can change diet to prevent the weight gain? Or are there ways or foods that we can eat that'll actually enhance the Mech inhibitor therapy? So this is something that's also going to be studied, and I'm actually opening a study here hopefully this fall to look into this further. The next thing I just want to mention for research progress would be preventative treatment. So there's always a lot of discussion about prevention and how can we keep these tumors from becoming symptomatic. So for the SPRINT trial that Dr. Gross was talking about, there was an arm where we did start patients on treatment with Mech inhibitors who had not yet had symptoms, and the results from that will hopefully be coming out soon. But what if we started when the tumors are still very small? So in my laboratory with Dr. Yuan Zhu, we studied 2 different types of ways that you could use Mech inhibitors for prevention. One was for cognitive, so looking at Mech inhibitors for cognitive or to improve cognitive deficits, and then one was for tumors. And so this is just showing for the tumors, in the mice, the tumors form very, very early on. You can actually start to see tumors about 5 days of life. And you can see here on this side, so this is what a nerve should look like. And then if you have a patient or a mouse with NF1, they will develop tumors. Generally, we can start to see the tumors around 30 days of life. But if you treat them from basically day 0 of life up until 21 days of life, that tumor actually does not really form. So we're able to prevent the tumor from forming altogether in the mice. And if you look at it even 30, 40, 50, 60 days later, they still have not developed a tumor. And more importantly, in the mice, they can have changes in the retina that can affect, or the ganglion cells that we know affects vision. And if you have treatment with the Mech inhibitor, that vision is preserved in the mouse. So I think this is something that's exciting and something that might potentially be for the future, but there's a lot of things we still need to learn: who's best or who's at most risk, who would best benefit from preventative treatment, what are the side effects, before we're able to really move this to the clinic. So the last thing I just want to say, there's a lot that we know about Mech inhibitors, and there's a lot of ways that we know that this can be helpful, but there's also a lot of things that we don't know. For example, we don't know how long we should treat and when we should stop treatment. We don't always know what happens when we stop treatment. Sometimes we stop treatment and the tumor grows back. Sometimes the tumor doesn't grow back. And we just don't know for sure what is going to happen until we actually try it. Does this affect fertility? As far as we know, it doesn't, but this is another big question that we really still are trying to learn. And so as of right now, we are definitely encouraging patients who are on this medication to use protection so that they don't become pregnant, for that potential risk to the baby, but also counseling younger children on the fact that this could potentially affect fertility in the future. We just don't know yet. What are the long-term effects of treatment? We don't have anybody who's been on treatment yet for years and years and years, so we don't know what will happen in the future. How can we prevent or avoid side effects? So this again goes to, are there ways that we could potentially use diet or other things to avoid the side effects? Which patients are most likely going to respond to treatment? There are a few patients who don't respond to treatment, or there are some patients who go on treatment and have really bad side effects and are never really able to have the benefit of this. So how can we determine who's going to best respond? And then are there other treatment options that may be better? So of course, everybody who's within the NF community knows that there are a lot of researchers out there looking at other options, because this may be just the start of a huge opening to new treatment options for patients with NF1. So the take-home points that I have today, so Mech inhibitors are definitely a promising new treatment for patients who have NF1-associated tumors. They're FDA approved for the Plexiform neurofibromas, but are becoming more common in other tumors such as gliomas and leukemia, for example. Mech inhibitor treatment should be monitored closely by somebody familiar with the medication and the side effects. And long-term and short-term side effects are not well known still, so the risks and benefits of treatment should always be considered before starting. So now I will go ahead and take questions.
Thank you, Dr. Bornhurst, for that really great comprehensive talk. Unfortunately, we're really out of time and have to move on. Maybe you can stay on and answer questions in the chat, and I'm going to hand it over to Kate now for some orientation. Thanks again, Dr. Bornhurst.
Yep, thank you.